Our next section involves disorders of carbohydrate metabolism, especially glucose metabolism, and especially diabetes and hypoglycemia. These are the things that we're going to be talking about in our next section. I want to let you know that a lot of the questions on the boards involve diabetic patients. There's new recommendations about diabetic patients, and they put a lot of these patients on the boards, even if it's a surgical case, even if it's a non-medical case, even if it doesn't involve an endocrinologic problem with diabetes. They put a lot of these patients on the boards because we do see more and more of these diabetic patients now because the definition of diabetes has totally changed. So we're going to be talking about that, and we're going to be defining the right way to assess these patients and so forth. So diabetes mellitus is a disease of glucose metabolism abnormalities. Right? You don't metabolize your glucose well, and really there's two types of diabetes mellitus. There's two types, type 1, and which occurs early in life. These patients usually have some kind of infectious process, usually some kind of viral infection, and they have an inflammatory process. Involves the beta cells, and basically after this is called insulinitis. After this insulinitis, they basically get their beta cells wiped out. So type 1 diabetics don't have any insulin, versus type 2 diabetics, where this occurs later in life. The patients are usually their body mass indexes are increased. They're obese usually. The type 2 diabetics, it occurs later in life, but these patients have insulin resistance. So if you measure insulin levels in type 2 diabetics, you'll notice that their insulin, especially early in the disease, their insulin levels are high. So they ask a question on the boards, well, can you have diabetes with elevated insulin levels? And the answer is yes, type 2 diabetes. Type 2 diabetes is an insulin resistant state where patients have elevated levels of insulin. Now, what happens in type 2 diabetes is very interesting. It seems that obesity is a permissive state. The more weight these patients gain, the more resistant their cells become to insulin. So the more you need insulin, right, to override this resistance. The more you need this insulin at high levels makes these people probably gain more weight. So it's a vicious cycle. They gain more weight because of the insulin resistance. And now, years later, what happens is the beta cells are exhausted, and what happens years and years later in type 2 diabetics, now the insulin levels later, they go down because the beta cells are totally wiped out, not in the sense of type 1 diabetes, they're not fibrosed, but they're so worn out from the constant insulin secretion that then eventually, years later, type 2 diabetics, their insulin levels go down. But generally, type 2 diabetes is an insulin resistant state. So please remember that. That's the big difference with type 1 and type 2 diabetes. There's also some other differences that we have to know about, and then it has to do with worse outcomes. Type 1 diabetics, across the board, if you take type 1 diabetics, they have worse outcomes. If you take their overall morbidity and mortality and so forth, they have worse outcomes. But that's because it's a more aggressive disease. They develop more renal insufficiency and so forth. If you take a patient, though, presenting with type 1 diabetes early on, because the type 1 diabetes hasn't had the disease for a long time, because you can't live without insulin for a long time, they usually don't have any vascular complications when they present to the physician. Versus type 2 diabetics, that basically they could have the disease for many years, and they don't know about it, and then all of a sudden the doctor picks it up, or they develop some kind of symptoms that the physician picks up, And once you diagnose type 2 diabetes, they could have vascular disease, they could have renal failure, they could have diabetic retinopathy right from the start of the disease. So even though overall type 1 diabetics have a worse prognosis, once you diagnose the disease of type 1 diabetes, you know that this patient hasn't had the disease for a long time. And you know that this patient can't present with disease that's been going on for years, so they can't have early vascular complications. A type 2 diabetic can have vascular disease from the start because they've had the disease 5, 10 years. Nobody knows how long they've had the disease. So what does this all mean, though, for us clinically? It means that when I see a type 2 diabetic right from the start, I have to screen this patient for vascular disease, for renal disease, for ophthalmopathy, for neuropathy. I have to look for this disease right away for microvascular complications in a type 2 diabetic. I have to look for it. I have to send them to the eye doctor right from the start. Even if they tell me I've never had any symptoms before and I just diagnosed this patient with diabetes today, I have to send them to the eye doctor right away to look for retinopathy, because this guy may have had the disease 1 year, 2 years, 5 years, 10 years, nobody knows. The patient with type 1 diabetes, once I diagnose the disease, even I know this is a worse disease after years, from the start though, once I diagnose him today, I know this guy can't have the disease for a long time. So what do? I don't look for microvascular complications right away. When do I start looking for microvascular complications? 5 years. So type 1 diabetics, we only start to look for microvascular complications. We only start to send them to the eye doctor 5 years after the diagnosis of type 1 diabetes. So please remember that. The definition and diagnosis of diabetes has changed over the last 7 to 8 years. It used to be referred to as any sugar over 200. Patients have diabetes if they have a sugar over 200, and which is probably right. Anybody over 200 at any time probably has diabetes. Then there was other theories about doing a glucose load and finding a sugar over 200 after 2 hours diagnoses diabetes. But now we've simplified everything. We've simplified everything, and I want you to stick to this definition. No matter what the books say, no matter what everybody else says, this is the easiest way to diagnose diabetes, and this is the more reproducible test. The test is called the fasting glucose, and if a patient has a fasting glucose of equal to or over 126, this patient has diabetes. I didn't say this patient has to be on insulin. I didn't say they have to be on medication, but they have diabetes. That's all that you need to know about this patient. Now, some people say, well, maybe, this test was done one time and it's wrong, and, you don't know what happened before and what this guy ate. Maybe you told him to fast and he didn't. So you want to repeat this test one more time within about a week or two apart, not closer by, right? You want to give this patient about a week or two until you give them, if anything has occurred before that you measured the sugar, well, you want to give a couple of days or about a week or two later until everything, has stabilized, and you want to repeat that sugar again. So really the definition of diabetes is a fasting glucose of 126 or over, so equal to or over 126 on 2 different occasions about 1 to 2 weeks apart. That is the definition of a diabetes, and once this patient has that, they have diabetes and they carry the diagnosis of diabetes for the rest of their life. Now, along with that, if a patient comes to us in diabetic ketoacidosis or hyperosmolar hyperglycemia, now diabetic ketoacidosis is the severe form of type 1 diabetes. Hyperosmolar hyperglycemia is the severe form of type 2 diabetes. Now, if they come to us with any one of these manifestations, we don't have to wait for a second time to check the sugar. They have diabetes. So in the outpatient setting, right, when the patient comes in with minimal symptoms or asymptomatic, the diagnosis is done through the fasting glucose. But if a patient comes to the hospital with diabetic ketoacidosis or hypersmolar hyperglycemia, these patients have diabetes, no question about it. There's no question about that. So that's the definition and the diagnosis. And then they ask us a question about a follow-up of diabetes. How do we follow diabetes? And the answer is the best test to follow diabetes with, to see how you're treating this patient, how this patient is doing, is called this thing called the glycosylated hemoglobin, or hemoglobin A1C. So that is the part of hemoglobin that has glucose residues on. And if I know the patient's glycosylated hemoglobin, I know what their mean sugar is the last 2 to 3 months. So I don't know what happens in the morning, I don't know what happens at night specifically, but I know what has happened, what's the mean sugar that this patient's had over the last 2 to 3, maybe 4 months. So I know if this patient's glycosylated hemoglobin is 6.5, I know their mean sugar in across the board in the last 2-3 months is about 125. That's why a glycosylated hemoglobin of 6.5, this patient has pretty much a normal sugar over the last 2-3 months. I know if this patient's glycosylated hemoglobin is 8, this patient's mean sugar runs about 250, maybe even a little bit higher. So just by that, I know what's going on in the last 2-3 months. It's a very, very important test. And we know now that it's one of the tests that we use to titrate the medication and to tell the patients to use more or less medication based on the glycosylated hemoglobin. It also serves another purpose. If you ask the patient, what their sugars run, they always tell you, it runs, 125, 130. They usually check their sugar only when they feel they're doing well. A lot of patients don't check their sugar when they haven't taken their medications, or where they're eating like a bad meal, what they're not supposed to eat the other day. They don't usually check their sugars after that. And that's why the glycosylated hemoglobin serves to tell us basically, is this patient's sugar running well, or what they're giving us on a spreadsheet when they come in every couple of months, does that correlate with the glycosylated hemoglobin? So it really tells us what the patient's doing with their management. It's a very, very objective way to look at the sugar over the last 2-3 months. Now, along with that, we want to know what the patient's sugars are throughout the day, because if I titrate my insulin levels to the patient's needs, then I need to know what's going on specific times of the day. So beyond the glycosylated hemoglobin, when the patient comes to me with diabetes, I'm going to ask them to check a couple of other things. I'm going to ask them to check a fasting glucose throughout the day, so I know what the sugar is in the morning time, when they get up out of bed, what the sugar is before dinner. So I could titrate my insulin and my sulfonylureas and my other oral hypoglycemic agents according to this glucose level. I also sometimes will ask patients to give me a postprandial glucose. This is a good way of assessing what happens also throughout the day. So I don't want this beyond to go above 200 after meals. I don't want my fasting glucose to be over 126. So if my glycosylated hemoglobin is 6.5 or less, and my fasting glucose that the patient gives me is less than 126, now I'm pretty sure I'm treating this guy really well. Throughout the day, the sugars are normal. I don't get any peaks. I don't get any lows. And my glycosylated hemoglobin tells me that the mean sugar is okay, and that's what I follow. And then I know my medication is just the right amount to treat this patient. So they may ask us also on the boards, what are the objectives of diabetic treatment? So the objectives of diabetic treatment is tight glycemic control. That's the new theory